As you all know, commonly it is in the left to right shunt lesions like a VSD, ASD, PDA, AV canal defect, AP window, and rarely it is in single ventricle physiologies with an increased pulmonary blood flow where we need to decide whether the patient should go for the first stage palliation, and very rarely congenital left heart obstructive lesions. So we'll go through some of the basic concepts. Now, how to decide on operability of the shunts, what are the indications for cardiac catheterization and interpretation of the data which we obtain by cath, and the limitations of these tools. So we know that PA pressure is a product of pulmonary blood flow and pulmonary vascular resistance. So in congenital heart disease, there is a terminology called as hyperkinetic PAH. That means the flow is primarily driving the PA pressure. The elevation in the PA pressure is because of the increased blood flow happening to the lungs. So that is a part and parcel of all large shunts. So that does not mean anything. It's part of the disease. So the issue of operability doesn't arise. Now, what we are concerned about when we speak of operability is something called as the irreversible PAH or pulmonary vascular obstructive disease, PVOD, which is characterized by elevations in the pulmonary vascular resistance. So this is the PAH which we are going to talk about. Hyperkinetic PAH is a part of any large shunt. So what are the factors which determine the development of this PVOD? Age, type of defect, increase in the pulmonary blood flow and PA pressure if sustained for a long period of time, airway and ventilation issues, high altitude, and other unexplained influences like a genetic susceptibility. Children with Brown syndrome can have earlier onset of irreversible PAH. And primary endothelial dysfunction also has been implicated, but they can have remarkable individual variability. So to decide, we look at all these factors: age and type of defect, the physical findings, the oxygen saturation, X-ray, ECG and echo, which is part of all evaluation of congenital heart disease, and cardiac catheterization study. So coming to the age and type of defect, the common post-tricuspid shunts like VSD, PDA, AV canal defect are all universally operable less than 1 year of age, almost. And this PVOD is uncommon before 2 years of age. AV canal defects have an earlier onset of PAH compared to a simple VSD. In an ASD, the onset of PAH, irreversible PAH, is delayed up to 4th or 5th decade. That too, only in around 10% of patients. So vast majority will remain operable late into adult life. And there is an earlier onset in sinus venosus ASD compared to a secondary ASD. And left heart obstructive lesions is a different set in which the PV hypertension is responsible for the PAH. So oxygen saturation, when we look, normal saturation generally favors operability, but not always. It can be a child with a normal saturation, but still will have very high pulmonary vascular resistance and pressures. But resting desaturation generally indicates a basal right to left shunt, which usually precludes operability. Now, I am not going to the details of physical findings because already you will be having case discussions. We all know what all findings a large shunt will have. And whenever there is not much cardiomegaly, no murmur or very insignificant murmur, PR murmur, all these are indicative of the onset of irreversible PAH. Absence of plethora in X-ray, absence of volume overload in the echo and X-ray. So when do we decide to subject a patient to cath study? If there are clearly operable findings, then we are not going to do cath. When there are clearly inoperable findings, then also we are not going to do cath. So when there are borderline findings, often it's a combination of many factors. That is when we decide to take up a child for a cath study. So a cath study for a PAH should be taken very seriously, in the sense it could be a life-changing decision for the patient. So meticulous care should be taken to avoid or minimize errors during each step of the cath. So first of all, you need to optimize the milieu of the patient in the cath lab. This is very important, especially in children, to avoid hypothermia, avoid over-sedation that can elevate the PCO2, which can interfere with the PA pressure. And ideally, the PAH caths are done on spontaneous respiration with minimal sedation. So it's an adult, means you have to do it under local anesthesia only. and avoid sedative agents which can interfere with the PA pressure. So how do we do it? We measure the saturation sequentially in the SVC, IVC, pulmonary artery, pulmonary vein, aorta. If it's a PDA, both ascending aorta and descending aorta. Then record the pressures in the mid-lateral right atrium, right ventricle, pulmonary vein or pulmonary capillary wedge pressure if the IAS is intact, pulmonary artery and aorta. So following this pressure measurements and oximetry run, we do acute vasodilatory testing with pulmonary vasodilators to assess the reversibility of PAH. By reversibility, we mean there is no PVOD. So then again you repeat the same samples, the oximetry run and the pressures. So this is how you do a hemodynamic cath. So now it is important to ensure that the data which you obtain is absolutely correct or to minimize the errors. Because we do so many calculations that itself is prone to errors. So we need to take care of all these steps, like starting with the leveling, zeroing and calibration of the transducer, selecting the appropriate catheter. There should not be any loose connections between the catheter and in the tubings up to the transducer. All air bubbles should be removed, and ideally you should correlate the waveforms along with in correlation to the ECG and check for any over damping, under damping, anything which can interfere with the pressure trace, and ideally measured at end expiration and obtain all the pressure data before injecting contrast. This is very important. All the pressure measurements should be completed before doing any angiogram. So similarly, when you take an oximetry sample, you should take the oximetry samples in the shortest time possible so that you get closest to the physiological state. Correct sampling site, avoid excess heparin in the samples, and it should be analyzed as quickly as possible after collecting the sample. So there is a criteria for significant step up at each level which are given in books, but generally we take a step up of 10% from the mixed venous to the PA saturation as a significant step up. Now, coming to the calculation of the cardiac output and shunts. Cardiac output is the quantity of blood which is delivered to the systemic circulation per unit time. And it is usually calculated by applying the Fick's principle, which is cardiac output equals oxygen consumption divided by the arteriovenous oxygen difference. So this oxygen consumption ideally should be measured exactly, but it's not possible. So practically we are assuming the oxygen consumption. So this is a Lafarge and Mitunen table which shows the oxygen consumption. This gives the values starting with from the age of 3 years up to 40 years. Depending upon the gender and the heart rate, it gives a value and you can index it to the body surface area to get the assumed oxygen consumption. In general, in a young infant, you can take around 150 ml per meter square as the assumed VO2. So, when you calculate the pulmonary blood flow, the formula will come according to the Fick's principle as VO2 divided by the pulmonary venous oxygen content minus the pulmonary arterial oxygen content, which is derived by multiplying the saturation difference with the oxygen capacity. So, the final formula will come as VO2 divided by PV saturation minus PA saturation into hemoglobin into 1.36, because each gram will carry 1.36 ml of oxygen into 10 is to convert the hemoglobin from deciliter to ml. So, this will be the formula for calculating the QP. Similarly, for calculating the QS, the same formula VO2 divided by arterial oxygen content minus mixed venous oxygen content. Mixed venous content is derived by 3 SVC plus 1 IVC divided by 4. The saturations are used here and you get the mixed venous oxygen content. So, VO2 divided by aortic saturation minus mixed venous saturation into the oxygen capacity, and the same formula is used to calculate the QS also. So, once you get QP and QS, you calculate the ratio and derive the QP-QS. So, since VO2 is in the numerator of both QP and QS, you can eliminate that, and this is a quick calculation of QP by QS, where this is the aortic saturation minus the mixed venous saturation divided by PV saturation minus PA saturation. So, this will give you a quick QP-QS once you take all these saturations. Now, there is an error which can happen when you are giving the patient 100% oxygen for assessing reversibility. So, normally in room air, there is something called as dissolved oxygen that is involved in the total oxygen content. That is oxygen bound to hemoglobin plus dissolved oxygen. On room air, this dissolved oxygen is very minimal, so we are not calculating it. But if the patient is breathing anything more than 50% FiO2, then we need to take the dissolved oxygen into consideration. So that means it has to be added to the oxygen content. So this figure of 0.003 ml into the PO2 should be added in the denominator. Otherwise, it will lead to an overestimation of the pulmonary blood flow and falsely it will lower the pulmonary vascular resistance. This is very important when assessing operability. Now, how do you calculate SVR and PVR? SVR is calculated by aortic mean pressure divided by RA mean pressure divided by QS, and PVR is PA mean pressure minus PV mean pressure divided by QP. And to calculate the indexed area, you have to multiply it by the body surface area. So that means PVRI. This is a value which is important, the indexed PVR, that is derived by multiplying the body surface area with the PVR. Coming to vasodilatory testing, we generally use 100% oxygen, inhaled nitric oxide, or more commonly a combination of inhaled nitric oxide and oxygen. So when we do a vasodilatory testing, increase in the QP and a fall in the PVR are favorable signs. Fall in the PA pressure is more reliable. As you are giving the nitric oxide, as you keep watching the trace of the aorta and the pulmonary artery diastolic pressures will tend to fall in a reactive pulmonary vascular bed. So that will indicate, that is a sign which you can see in front of your eyes, which will indicate a reactive pulmonary vascular bed and operability. Now a QPQS of less than 1.5 is a small shunt, and a QPQS of more than 2 is a large shunt which need to be addressed. And if there is a QPQS less than 1, it is indicating a resting right to left shunt, and it may preclude a closure of the defect. Now the ratio between PVR and SVR and the PVRI values are used for in the criteria for operability. So if the PVRI is less than 6 Wood units with a ratio less than 0.3, it is operable. If the PVRI is between 6 to 8 and the ratio is between 0.3 to 0.5, it's a borderline operability or a high risk. You can do a high risk surgical closure, you can consider. If the PVRI is more than 8 and PVR-SVR ratio is more than 0.5, it is inoperable, or the so-called PVOD. Now there are a lot of errors in the cath data. First of all, we are assuming the oxygen consumption, sometimes assuming the pulmonary vein. Then there is an absence of a steady physiological state. Children can become agitated and sometimes they become hyperventilated. So a lot of errors can happen. Improper sampling, I told you, to measures to minimize, and not considering dissolved oxygen. This is very, very important. That will lead to error in the calculation on oxygen. Now this is a baby with an 8-month-old baby with a Down syndrome. I just want you to look at the PA pressure and the aortic pressure. Here you can see in a large VSD, the systolic pressures will always remain same. So we are not looking at the systolic pressures, we are looking at the diastolic pressures and the mean pressures. So here you can see that the systolic pressures are more or less equal, 80 and 80. This is on room air. However, the diastolic pressure in room air is 42 in the PA and 46 in the aorta. There is only a 4 millimeter difference. And the mean pressure also similarly, PA mean is 4 millimeter less than the aortic mean. So this is the basal data. And however, when you give oxygen, look at what has happened. The PA diastolic pressure has fallen markedly. It is now 30 against an aortic diastolic of 50. So there is a gap of 20 millimeters mercury between the diastolic pressures in both the vessels. Accordingly, the mean pressure also gap has widened. So this is a favorable sign of operability. So the QPQS, which was 1.8 in the room air, has increased to more than 4, and PVRI, which was 9, has fallen to 3.2. So this is favoring operability. Now in adults you often come across ASD with PAH. The problems with ASD PAH is there are no hardcore clinical signs which will point towards a inoperable state other than a resting saturation. So when there is an echo evidence of an elevated PA pressure, like if the RV systolic pressure is more than 60, then we need to do a cath study to really assess, because it is very uncommon in a simple ASD which is having just a hyperkinetic PAH. A resting desaturation of less than 92% will indicate a right-left shunt and does not require a cath study. And we do the cath, and sometimes we treat with pulmonary vasodilators, again redo cath, and again the repair, treat strategy is adopted in many patients with ASD PAH. Okay, this is a 15-year-old child with ASD. I will show you. This is the PA pressure is in blue, aortic pressure is in red. You can see that the PA pressure is only around 20 millimeter subsystemic. So this is a very unusual elevation of the PA pressure for a child with ASD. and QPQS at base is 1.8, PVRI is 10.3, which is very high, and PVR-SVR ratio is 0.5. Now what happens on nitric oxide? There is some separation. You can see that there is some separation between the two pressures, but however the absolute PA pressure is still high, 86 systolic. The QPQS is marginally more, PVRI has marginally fallen, but still nowhere near the operable range for an ASD. So we have to treat this child with pulmonary vasodilators and reassess if at all, but more likely this PA pressure and PVR is unrelated to the ASD in this patient. Now some interventions are there to decide on operability. Commonly done is the test balloon occlusion of the PDA. So whenever you do, this is a 25-year-old male who has got a very large hypertensive ductus. Here you can see that the QPQS and basal is 1.5 and PVRI of 11.5. This is the trace in room air. You can see the pressures are equal in both aorta and PA. Now on oxygen what happens? There is some increase in the QPQS 2.7 and PVRI is still high 9.6. So when you try to test occlude this ductus, you can see that this is on oxygen. You can see that there is some fall in the pressures in the pulmonary artery, the lower systolic pressure. It is 20 millimeters subsystemic. So now when you occlude the ductus, you can see what is happening. There is a wide separation of the pressures. The top one is the aortic pressure and bottom one is the PA pressure. Now you can see what happens after 15 minutes of a duct occlusion. The PA pressure has fallen to around, markedly fallen to less than half of the systemic pressures. This generally indicates that you can close the ductus, but need not necessarily mean that in long term there may not be any PAH. Sometimes they can have a rebound also later. But generally if you see this pattern, you can go ahead and close the ductus. So to conclude, a clinical examination with other non-invasive tests allows decision making. Cath study is done in borderline cases. Basal data in cath carries more value, and limitations of the cath need to be kept in mind while deciding on the operability. Thank you.